apologies?
No, convener, no apologies.
Yeah. And any declarations of interest? No. No. Okay, right. In that case, if I can move on to item 9, we'll just take this one just now, the duty of candour annual report, and that's Sarah and Andrew.
Sorry, just getting used to this new interface. Duty of candour, yeah, so just before we started the meeting, we were just discussing it. Duty of candour, that people probably are aware of as a concept, is a legal obligation for organisations to provide a duty of candour report on an annual basis. So that's been in place with the NHS for the last couple of years. And that means we're getting used to the template and how best to present it. And the obligation is to publish a duty of candour report and also to make sure that's accessible to the public. So that goes on to the NHS public-facing website. And I'm sure it's the same for social work. I'm sure Sarah will add some details around how that's managed within that service. There is a very clear decision-making process for deciding if something is duty of candour. So duty of candour obviously arises from harm, but not any harm, and not always even harm where there's been clear fault from my perspective, from the clinical side. So there is a clear decision-making in that there has to be a level of harm which is permanent and has those kind of ramifications, and it also has to be as a result of the service, weaknesses within the service. So, as I said, there is a clear flowchart, and that means that we apply that at the point of recording harm, so an incident reporting. We prompt with the question, is this duty of candour? And that's organisational duty of candour. And just to reiterate, there's always a professional duty of candour. So what I mean by that is if something does go wrong and it's due to a clinical interaction. So, we've got the wrong dose of drug, with the process has not been as per the protocol, then there's still an expectation that people will meet those professional duties of candour and go and discuss with the people who've been affected, the patients in this case. So the professional duty of candour, that's not what the organisational one is. It's a legal obligation that's enshrined in legislation. And this, as I said, this is our second duty of candour report. We do try and make sure we pick up at the right time anything that may reach that threshold for duty of candour. And you'll see in the report that's included in the appendix that we have recorded 6 cases this year, and all of those were around unexpected deaths. So, in the detail of those, you'll see in the learning points, there's a kind of really a learning point for each one. And as you can appreciate, that's not the totality of our response to those to unexpected or deaths that have resulted from complications, etc. There'd be a whole clinical review. There would be mortality and morbidity meetings. There's also, for the majority of these, a formal serious adverse event review. So what you're seeing in the duty of candour report, in some way, is trying to demonstrate transparency to the public. I think that was the rationale behind the legislation. It's a lot more advanced than England, so I think there was an element of Scotland feeling it needed to align with that. Does it add any value to any of the learning? At this point, I think it's very much, we're still trying to get used to it and see what the application is. But I think it was that statement of intent from Scottish Government that this is how our organisations are going to be, and we want them to be seen as open and transparent in this particular area. So there's the papers there to cover over both the NHS one and then the work from social workers. I mean, these are distinct entities, both requiring to produce duties of candour. I know that there has been some discussion, is there a way to integrate it, but I think that's an artificial integration. I don't think it's something that we could really do, and the other bodies have to report it anyway. So it's maybe just making sure that people can get sight of that. It is available on the public website, as I said. I'll stop now, and I don't know if Sarah anything else that she wants to add in from her perspective.
Thank you, Sarah. You want to come in?
Yeah, thanks, convener. Thanks, Andrew. I think Andrew has outlined really clearly the principles, which are the same across both. There have been no incidences of duty of candour that have been reportable within the time period of the report provided to committee. Andrew's absolutely right. We too need to make sure that we are transparent, and we should be publishing the report on the council's webpage. I have asked for some advice from the Care Inspectorate in terms of just the kind of point that Andrew's made about both duty of candour requirements of both NHS and council, and whether there's a determination from any of the scrutiny bodies about joint reporting, or whether we retain the separate responsibilities for reporting. I haven't had a response back to that yet, but I'll share that once I do have it. So really, we've presented the reports separate today, and we have made a suggestion previously that we do join them, but whether we should do that, we should be able to get a response back to give us some guidance on it. Fundamentally, the template that has been included in the appendix for committee today outlines really how we make sure that we continue to support learning development of our staff around the awareness of duty of candour, the awareness of when we do have near misses or make mistakes, that people are aware either to consider it as an incident reportable under duty of candour, and really just to make sure that we're maintaining that and sustaining that, despite the fact that we don't have any reportable incidences this year. Happy to take any questions. Thanks.
Thank you. Excuse me. Thank you very much, Andrew and Sarah. Does anyone have any questions? No, doesn't look like it. Well, thank you very much for the report, and I think it is I suppose heartening that it's in small numbers, but I think that candour and transparency and I think for families is very important. So so thank you for the report. So with that, if I can move back to item 3 on the agenda, the minute now. I don't, as usual, I don't intend to go through it page by page. But if anyone has any comments, questions, or corrections, if you can let me know, either put your hand up or put something in chat. No? Okay, right, so I'll move that out of the way. And moving on to the action log, again, this is for noting. I don't know if there's anything that anybody has any questions or comments on in relation to the rolling action log. No? Again, nothing. Thank you very much. Okay, I'm going to now move on to the HSEP complaints and feedback performance report. It's a bit of a mouthful. And is that Suzanne? There we are. I'm trying to find you on my screen.
I'm trying to find the mute button, but we're all on different buttons today. I think Mandy's going to cover the paper from the NHS perspective, so I'll pass over to Mandy. Thank you.
Good morning, everybody. Can I just draw your attention to page 3 of the report, which talks about NHS Forth Valley, and between the period of April and September of this year, the partnerships received a total of 8 complaints that have come in through patient relations. 3 of them were dealt with at stage 1 with a 100% performance. The other 5 were dealt with at stage 2 with a performance of 60%, which gives us an end of year performance so far of 75%. Over the page, it shows that the top themes coming out between April and September remain clinical treatment, staff communication, and staff attitude and behaviour. The Ombudsman, between April and September of this year, it's noted that the partnership have not received any complaints that have been referred to the Ombudsman so far. However, we do note that between April and March of our previous year, the Ombudsman had received 6 cases. 2 of these cases do have 2 complaint numbers, so the numbers do look slightly higher. The committee requested a more detailed report and overview of those 6 cases at the last minute around learning what's been taken on board following the recommendations. So we've done a deep dive around the learning to show what changes have taken place. So the Ombudsman complaint around Unit 4 at Falkirk, an apology letter was sent, and then recommendation 2 showed that there was an introduction of a new patient information system. A specialist geriatrician is appointed into post now within Falkirk community, and a portfolio GP with advanced nurse practitioner support and discharge process and letters to ensure that letters are sent out in a more timely manner. The service manager for Falkirk has met with a consultant to ensure the reflective process of learning was identified and implemented through the appraisal mechanism. The Ombudsman were happy with those recommendations with the evidence that we'd sent them, and they closed that case now. There's one still sitting with the Ombudsman awaiting a decision around Unit 1 at Falkirk, and one with Community Mental Health Team East and Kersey Bank that we're still awaiting a decision on from the Ombudsman around those 2 cases. We did receive an upheld decision around Unit 3 at Falkirk, and the recommendation 1, the apology letter, was sent back in August. Recommendation 2, the head of nursing met with the senior charge nurse from Unit 3 and discussed the report, and there's been a staff brief produced for the staff within Unit 3 in Falkirk, and that's been circulated to all the staff to identify the learning. The senior charge nurse, along with the clinical nurse manager, provide close monitoring of these actions, and in addition, the discharge team at Forth Valley Royal were contacted to ensure that communication between patient and families is realistic around the provision of single rooms, which are limited within the Falkirk site. Recommendation 3, I ensured learning within the patient relations team to ensure that processes are highlighted around the Ombudsman's findings around communication and have been implemented. Recommendation 4, the staff brief produced by the senior charge nurse detailed the recommendations relating to the fluid and dietary requirements, and the senior charge nurse remains focused on timely assessments for each patient when they've been transferred over into Unit 3. The Ombudsman were happy that these recommendations were met, and they've closed that case as well now. Within Ward 1 at Bowness Community, we're currently working through recommendation 2, 3, 4 and 5. Recommendation 1 has been completed, where I do know that we've got evidence around recommendation 3, 4 and 5, where training is ongoing out in Bowness, and we're in the process of implementing training that will cover recommendation 2. I will be happy to share the evidence once that's all been provided. And there was an initial request for information from the Ombudsman around woodlands. The Ombudsman received their information and they're happy. They're not going to progress with a full investigation into this complaint, and they've closed the case. Thank you. That's all I've got for Forth Valley, unless you've got any questions.
Thank you very much. In that case, I will open up to questions around this part of the report. Does anyone have any questions or any comments around this? No? Oh, Angela.
And every time I turn my unmute on, I lose my picture. So sorry. So hopefully we did the action, the kind of deep dive that colleagues had asked for, and Brian has supported us as we've done that. So hopefully we've got what you've needed, and as Mandy says, we'll reflect the report so that the committee gets the information they need. In relation to the Ombudsman, we've been on quite a long improvement journey in health in relation to trying where we can for families or carers or individuals who have got concerns and they raise them with us for us to address them as best we can. So they never need to go to the Ombudsman. Of course, everyone can go to the Ombudsman. And if anything does go to the Ombudsman, I think Mandy's highlighted that what we do is we're really active and proactive around making sure we've got the learning up front. But what we have been trying to do is to make sure that we understand anything from our investigation and our response and why the Ombudsman would uphold something. So we've really used it as a quality marker over quite a long period of time. And what we have seen, so families are entitled to go to the Ombudsman, of course they are, and we always make sure that families have the information to do that. We do want to be given the opportunity to deal with it at local level, but where they do go to the Ombudsman, our endeavour has been that if things not to be upheld, so that the families can take confidence that we've dealt with things really well. So we've had a few things, some of the Falkirk ones have been quite historic, and we haven't been seeing patient complaints or activity particularly around that the last 6 months or so. However, in relation to any family, if we get the investigation right, if we listen, if we show them that we've taken action, then we would hope if it goes to the Ombudsman that there wouldn't be too many recommendations. But where there are recommendations, we take them really seriously, and it comes through the committee, and Mandy's indicating that we'll make sure that that level of detail comes here for assurance. So it's just really a bit of a broad stroke. We've been on this journey for quite a long time. We know that the Ombudsman can be very critical of complaints processes and how the actions we've taken around that. And again, we've worked really closely with the Ombudsman in terms of supporting our staff and for our own process learning to try and make sure that we do as best we can, and the Ombudsman are satisfied in terms of how we respond. But it's an ongoing process, this one. I think we'll always have a focus on it. But happy to take any questions in support of Mandy's great presentation there.
Thank
She
you.
was very nervous. She was very nervous, was Mandy?
I shouldn't be nervous.
Try not to be.
We're all lovely.
Very nervous.
I think that report, the reports, that depth of information, I think is really helpful, and I think it does give assurance that where issues arise, and across the whole system, health and social care, we're working with human beings, and we all are human beings, and sometimes there are mistakes and things that aren't quite right. So I think having that depth of information is really helpful. Fiona, if I may, I just have terrible problems with the WebEx doesn't seem to like my machine, but in relation to staff attitude and behaviour, and it'd be interesting to see how other colleagues have used in this. And indeed, at Clinical Governance Working Group this week, we had a discussion around an element we were looking at, and staff attitude and behaviour. If people don't have absolute mutual respect for one another or for those that we serve, that's not acceptable. So I would want to say that from the outset. But so many times when people are at the end of life, or when families are facing a loved one's mortality, or they're so anxious about their loved one, sometimes our staff have done a really good job, but it just hasn't made it for that family, and it's very human chemistry as well involved. So it's a really complex picture, and what we try and do, and the complaints handling process, as you know, must be fair to both families and those who have got concerns and complaints, as well as staff. And our job is to make sure that we do that. And I'm sure the staff think we're on the patients and family side, and the families will think we're on the staff side, absolutely. But what we really do try and do is understand the context in which that interaction or people's lack of respect has happened, or they've seen not to be caring. So we do really be thoughtful about that. We don't ever give defensive responses, but we do try, if possible, to show families context so that we can understand. And we've done a whole lot of work in supporting our staff, particularly around unconscious bias and looking at first impressions and communication. Every single complaint has an element of communication at so many different levels. So we've got a whole programme which is very experiential of how it feels to have someone who probably does care but is distracted, so it is a really complex thing, and I wouldn't want people to think that within that there are things that are not acceptable, and we will deal with them, absolutely, and we deal with it through support as well as reflection, but it is a complex thing, and we do also have to understand
the context, and families are very understanding and forgiving of us quite a lot, actually. So I just want to say that in that is a multifactorial picture, and we are wise to all of it, and we don't just, in case anybody thinks we're being too tough on staff. Now, we will be tough if that's required, absolutely, but what we do try and do is let people reflect and show that their impact and how that's made somebody feel. So it's just in case somebody thinks that that's just about staff not caring, it is quite a mixed picture in there.
Thank you very much for that, Angela. I'm going to paraphrase something because I can't remember the exact quote, but it was something that people don't remember what you do, they remember how you make them feel. So
yeah, it's Maya Angelou. I think is it Maya Angelou? Yeah, absolutely.
Yeah.
Live by it, and it's a perfect quote for this. But I just want colleagues to be assured that we look at things in the round and the fairness to all, and we understand the context. So, but we do mostly support it through staff reflection and experiential, and it's just that's exactly what drives us. So absolutely on the money, Chair.
Got the quote right, and I must be a first actually.
I'm quite thoughtful about this transcribed now. I've already been in the Falkirk Herald this week.
So, does anyone have any questions or anything they would like to add? I'm just having a look through. Well, in that case, thank you very much, Matthew, for the report.
Thank you.
And I will move on now to the complaints report on Woodlands Resource Centre. Martin? Yeah.
Hi. Members will recall that at our last meeting, when the complaints report, it highlighted that there had been 10 complaints received about Woodlands, and members just wanted an assurance that there weren't any particular issues with Woodlands Resource, so wanted, I guess, a bit of a deeper dive into those. The report really just highlights the findings from that review of the complaints in Woodlands. You will see that there were 10 complaints. Of those 10, 9 of them were not upheld. The report goes on to highlight kind of the breakdown around the range of complaints. There were 3 about treatment, 4 around staff attitude and behaviour, 2 complaints about communication, and 1 about the date of appointment. The report highlights that 1 of those complaints was partially upheld, and it goes on to highlight the learning that was taken forward from that and the changes that they've put in place. I think for me, really, I guess the positive thing for me was when I started to ask the questions around this, managers knew exactly about the complaints. They knew what they all related to, they had discussed them, they'd considered them, and they had taken forward any actions. So really, hopefully this report just gives an assurance that there isn't a significant issue there, that the management team do review complaints seriously, and they take any actions as soon as possible to address any issues. So hopefully this report just gives members an assurance, as I said, that there isn't a significant issue at Woodlands, which I think was the concern when you saw the numbers of complaints there.
Thank you very much. Thank you very much, Martin. I think sort of reading the breakdown, and even where there was complaints, that there was action as a consequence, whether that was trying to explain context or having a offering further discussion. So I think that's helpful. I think certainly helps when you're seeing a number coming from one service, and to give that context and that information. So very much appreciate that. Can I open this up to any other questions or comments? Stephen.
Thanks, Fiona. No, just an observation. Yeah, I think it does provide the committee with that reassurance. I remember the discussion we had at the last committee meeting, and without putting any additional pressure on the workers, that I think those deep dives are really worthwhile for committees such as this. So good report, and it's good to see that although there was those 10, that 9 weren't upheld, and action was taken. So Yeah, so thanks for that. Thanks, Martin, for that.
Thank you, Stephen. Do you have any other questions or comments? No. No, well, with that, we just note the report. And if I can move on to agenda item 7, the overview of inspection reports on national publications. I'm trying to find you on my screen. There you are, Suzanne.
Thank you. The report provides an overview of the national inspection reports and publications of interest to the committee. The inspection reports are noted at section 4. Due to the pandemic, the Mental Welfare Commission visits had been suspended for a period of time, so there were no reports published since the last update to committee. The Care Inspectorate have visited Bunbury, and this was as part of their inspection programme to evaluate services during the pandemic. And we've put some information in the report there. You'll note that this resulted in a grade 2 with 1 requirement and 1 area of improvement identified by the inspection process. The service has made significant efforts to address these issues, and this was noted by inspectors during a follow-up visit in October. They also gave a further extension to complete the remaining work. So details of this in more detail are set out in the report, and we've also included that in Appendix 1 as well. Appendix 1 also includes progress updates on Care Inspectorate and Mental Welfare Commission recommendations for services that we previously provided to the report to the committee. Sorry, so this is just a further update on progress and noted where some of those actions have now been completed. Appendix 2 provides a summary of the fortnightly reports to the Scottish Parliament on the Care Inspectorate inspections, and that relates to Falkirk providers. You'll note that with the exception of Bunbury Care Home, there have been no reports for services in the Falkirk area presented. Section 5 of the report provides an update on 8 national publication reports that have been published since the last committee update. It also advises on a response submitted to the Mental Welfare Commission, and that was in relation to the findings into their investigation of the care and treatment of a woman with a learning disability. And we had presented that report to committee in February this year. Appendix 3 provides a summary of these reports and notes our response where we need to do anything to those publications. So in conclusion, the committee are just asked to note the report and happy to take any questions or with colleagues. Thank you.
Thank you very much, Suzanne. If I may, I'd just like to ask a quick question because on Bunbury and that area of improvement around the anticipated care planning plans, which I think obviously is proved to, which is very important, has been proved to be very important, and you said that there's been progress made on that. I'm just confirming that that's what I heard, that there's been progress made in that area, and the Care Inspectorate were happier on their return. Do we know when they'll again look at the evaluation of the service itself?
I can maybe pick up the point. We did put in Appendix 1, so the update on the care anticipatory care plans. So the Care Inspectorate have recognised that had been met, so that has been a completed action. They had until the 30th of November to complete the remaining. I don't know if it's scheduled, but perhaps Martin or Lorraine can update.
Martin, did you have? Okay.
I haven't had any update. I'm not sure if they've been caught up in a wider programme of inspection given the current situation in care homes. But I suppose the fact they haven't prioritised coming back maybe take as a good sign. But as soon as I hear, I can let you know.
Excuse me. Has anyone got any questions or comments?
You're not.
Stephen,
it's just a wider one about one of the reports, and it's not specifically obviously relating to Falkirk, but it mentions about the guardianship for adults with incapacity, about the lack of support and supervision for private guardians, and I know potentially knock-on effects into delayed discharges. Are we seeing that in Falkirk? Are we able to provide that support and amongst everything else that we're doing? Is it not an issue?
Can someone come in on that?
Good.
Martin.
Maybe want to take Roger first, given he's a practitioner in the field.
People keep on moving. For some reason, this keeps moving around my screen. So 1 minute you're there, and then the next minute you're somewhere else. I see you now, Roger.
Thanks, Fiona. I have to be honest that we, the mental health officer team, do not are not able to support private guardians as much as I think we all would hope to be able to do. And in some cases, that's something that we don't see as the top priority when other things are pressing, like the Mental Health Act, immediate need, or actually working on application reports, mental health officer reports to the court. So we don't always support private guidance as much as I think the Act expects us to.
Thank you, Roger. Martin, is there anything you would like to add to that?
I mean, unfortunately, I could barely hear Roger there. I don't know if it's my internet connection there, but I did pick up that I think we're not doing enough, and I guess I share that view as well. Part of the restructure work that we're doing around the social work adult service is actually looking at how we can strengthen our response, particularly to mental health cases. There's also a lot of work ongoing nationally, or there has been, around reviewing how we engage with people through the AWI process. Falkirk was part of a working group with government looking at, I guess, our processes. I think for me, one of the reassuring things was our processes are fine. We just need to make sure that we stick to those processes and train them out much wider than we have done. So we began a piece of work just at the start of COVID, a piece of joint work across the whole partnership and with the acute hospital, looking at, I guess, our processes and how we implement them. That work will carry on over the next few months. I think this week we had a report back from Scottish Government around their findings around the review of AWI and how we engage with people. And we're currently looking at that to see if there are any further lessons learned. So it is a work in progress, but I would hope that going forward, we provide people a much better response. The fact that we have quite low numbers of mental health officers within the service and that we haven't really focused our resource, I think to target mental health and support private guardians is an area of work I'm really keen to develop. It may be helpful if perhaps in 6 months' time I'll bring a report around progress with that to this committee, and hopefully you would hear some really positive moves that we've made over that time. And I could also tie it into the findings of the Mental Welfare Commission report. Don't know if you remember, probably about a year ago, I brought a report around, I think it was the Miss ST case. It was a Mental Welfare Commission case that highlighted some issues around AWI. It may be helpful if I pull that together and give you a fuller update in a few months' time around progress there.
Yeah, I would certainly find that very helpful if you were able to do that, Martin. Stephen, does that answer your question?
Thanks, Martin and Roger, for that. Yeah, I mean, it's good it's been looked at. It's obviously a growing area when you see the percentage increases every year. So it's something that's only going to become more of a need for us as we go forward. But yeah, it'd be useful to have a look at it in 6 months. Thank you.
Just on the question of low numbers of mental health officers in the service, is there issues around recruitment, training? I'm aware that there is a kind of Scotland-wide numbers of mental health officers are not necessarily huge, and I just wondered what we do within Falkirk to try and increase that number.
If I can come in here, I mean, actually, I think Falkirk have a very good record of training MHOs. Probably, besides the council, we probably have one of the better records of training MHOs, and by and large, we recruit them fairly well. We recruit and retain them fairly well. They do get paid less than most other councils, so it's quite, I'd say it's quite positive to see that we're retaining MHOs despite paying lower rates in surrounding councils. And so I don't think that's the problem. The problem is just, as Stephen was saying, the amount of work over the last 5-10 years has just steadily increased, and there's been no increase in the capacity and the amount of MHOs there.
So I see that the issue isn't necessarily the numbers; it's the fact that it's keeping pace with the amount of work that's required. Right, thank you for that explanation. That's really helpful. Does anyone else have any questions or comments? No. Well, thank you very much for that report, and I shall move on to it. I'm just make sure I'm in the right overview of local oversight arrangements. That's Suzanne again.
Yep, thank you, Chair. The report provides an overview of our local oversight arrangements, and this has been updated to reflect work and business of these groups since the last report to committee. So the report's providing updates on the Public Protection Chief Officers Group, the Adult Protection Committee, NHS Forth Valley Clinical Governance Arrangements, the Care Home Assurance work, and the ADP, the Alcohol and Drug Partnership. All groups are continuing to meet, and members of these groups are here today if there are any specific questions arising from the report. So it's just a brief update. So in conclusion, you're asked to note the report today, and happy to take any questions with colleagues. Thank you.
I'm muted and then I'm unmuted and I'm muting myself again. Does anyone have any questions or comments around the arrangements? Any questions? No. Okay. Well, thank you very much, Suzanne, and thank you very much for the report. We're on to item 10, the hospital acquired infection performance report, and I'm trying to find on my screen. Tricia?
Good morning. Obviously, during this quarter's activity has been quite significant, with our infection control service expanding its role out into supporting care homes during the pandemic. Everybody's probably fully aware that we're now in the second wave of the pandemic, and at the moment Clacks and Falkirk are in Tier 3 and Stirling's in Tier 4. So far, our inpatients have not met the peak that we had in April of 60 inpatients. We've not met that yet, but at present, Forth Valley is still sitting as one of the lowest wards to have hospital-acquired COVID. The national average is sitting at 3.7%, and we're sitting at 1.8%. So we are doing things well, and that's including our community hospitals. Our ongoing work continues. We've not been allowed to stop any of the normal activity. So our work with enhanced surveillance continues. In July and August, we saw some peaks with our E. coli bacteremias with healthcare associated cases, but they seem to be related to patients who are delayed in seeking treatment. Because at that time we were in lockdown, people were reluctant to contact their GPs or seek advice. Generally, our work with our Staph aureus bacteremias, device-associated bacteremias, E. coli bacteremias, and our Clostridium difficile work continues. And during this quarter, we've not had any in Falkirk or Bowness. our estates works continues, and that has been continuing. There is a robust compliance group in place now that provides assurance. We did see during this quarter that Bowness's compliance dropped to just under 90%, which brought it from a green to an amber. But when we looked into that, we realised that the audit process was restricted because of the activity with COVID, and that had reduced the overall scores. But with the ongoing work with domestic services and ourselves, we have no concerns that it was part of the reporting structure. General outbreaks, we have none to report in this quarter in Falkirk or Bowness, and we've also been asked by Health Protection Scotland to trial a new electronic reporting process for Health Protection Scotland. We've not actually had many to report during that quarter. So we're all sitting there ready to go, but we've not actually been able to use it. And that's really a quick overview. Suzanne mentioned we've got ongoing work with the Care Home Strategy Group, and that's been a really positive, proactive work that's supporting the care homes, new innovative ways of working, and relationships that can only have a positive outcome for everybody involved.
Thank you very much, Tricia. Does anyone have any questions around the report?
Fiona, it's Angela, sorry.
Sorry.
So just wanted to support everything that Tricia said, and again we'll keep developing this report in terms of what the committee needs, but just the teamwork across health and social care, including our care home work, has just been fantastic in terms of coming together to look after those in hospital and those residents that we have in care homes. So it's such a team, it's just a team effort, and I just wanted to draw the committee's attention to the hospital onset COVID transmission rates, and it often does reflect what's happening in the community in terms of those transmission rates. But with all of the steps that we've taken and the way that the staff work, and then indeed the compliance of patients, residents and everyone, relatives as well, we have managed to have a fantastic performance. We had in the first wave too, and we continue that, but it is a huge team effort and everyone is taking it so seriously. So we're just so grateful for everyone and all the efforts of people in the community to help prevent COVID coming into any of our places of care. So but again, we're really happy to take questions, but it's been such a team effort.
Thank you, Angela. I was interested in the issue around the increases in E. coli and that link with people not seeking treatment, and said that they're going down a bit. Whether I suppose whether the information around how GP surgeries are operating is reaching people and reaching them in a way that they understand, because obviously it's really important for people to seek treatment, particularly around infections where they can end up being admitted to hospital when they may well have been able to be treated in the community. And I suppose I just wonder if I know that there's national messages around GP services, and I know that there's things going out on the NHS Force Alice social media, but you know, I suppose it's that bigger picture about how we reach everyone to make sure that they know about services being available.
I don't know whether Tricia wants to start off and me coming in, or because there are very specific patient groups that we think have not been. And I know Tricia used the word reluctant to come, but I think people were trying our best to protect the NHS, I think. So I think people were trying to do that. I don't know whether, Tricia, you wanted to say anything in particular, and I'm happy to.
That seems to be our hypothesis. Although GPs were open, people didn't want to bother the GPs because they didn't feel it was important. And this is a whole part of especially with the E. coli programme, it needs to be wider than the hospitals, because to reduce E. coli, we need hydration, we need to stop people getting constipated, we need to encourage people's mobilisation. So it's so much bigger, and that's something we need to take back to HPS, that we need to look broader and involve different partnerships to encourage hydration, encourage the mobility, stop constipation, that will help reduce the rest of these patients. And there are some E. coli that we have no impact on, especially the hepatobiliary ones with the gallstones. We can, there's no intervention we can put in to prevent that. But it's just how we can get the support out there to the people who need it.
Fiona, just if I might support Tricia, so the E. coli target is a national one, and we do all have programmes to try and prevent that, both in hospitals and, as Tricia said, in terms of healthcare, which we saw the kind of the main infections. I guess in terms of, we discussed this at the IJB last week as well, so I guess it's about how we get the information, just picking up your point, to people in the right places at the right time, and the constant messages, which is much broader than our GP colleagues as well. So all of our healthcare professionals and health and social care colleagues that are working alongside people to encourage people to do that. And then we know the more information that we give people, the better choices that they make, and if they know where to go for advice. And again, the public have just been trying, as they have been, to make sure that the health service was protected. And I think that's what we've seen. So yeah, it's going to take a lot of messaging, and we're going to keep giving that message, as people are incredibly supportive of us all, and they don't want to add or what they think might be a burden where we need to hear from them. So I think we just need to keep going with the comms and all different medias, but we need to keep doing it over and over again. And all of us and all of our roles need to encourage people to do that. So I think it'll be an ongoing focus we will need in particular.
Yeah, I think it is that challenge. You know, different messages at different times, and trying to reinforce that services are open.
Absolutely.
And across community as well. And I think I'd mentioned around our partners in the third sector, and that they've got a role to play. You know, I want to play in terms of making that connections with people on the ground as well.
Absolutely.
I'll open up to any further questions or comments. No? Well, thank you very much, Tricia. And I shall move on to reporting on locality working. Is that Lorraine that's coming in on that? No, it's Martin again. Thank you.
Thanks, Chair. This report might have been better termed ability to report on locality working, because it doesn't actually report on locality working. What it does is it gives members, I guess, a framework for localities reporting into this committee. The report really highlights that we now have established our 3 localities. We have locality managers in each of those localities, and within those localities they've established their management teams, and that's entire partnership management teams for each of those localities. So the report highlights that, similar to this committee, those locality meetings look at a range of areas, from care assurance across all their services, and budget, a particular focus on palliative and end-of-life care, community supports, locality plans and specialist services. And really this report highlights that when we are now where we are with those localities, this committee can ask for reports within those areas if you see fit. So the recommendations really are that you consider that regular reports can come to this committee, and you consider any topics that you would want those localities to bring forward to this committee. Happy to take any questions, but hopefully that's enough of a background.
That's helpful, Martin. Thank you very much. Can I open it up in terms of that question about bringing reports back and what the committee feels might be helpful? Oh, well, I'll start then. I did note that the themes to be scheduled for future locality meetings. That the first one was around care assurance across community services, and that feels like something that would fit into what the committee considers. So, I mean, obviously, it's great now that the locality managers are all in place and have their systems and teams in place, and that's fantastic. I'm really pleased about that. And I suppose I'd probably like to be guided about what sort of timescale we would be talking about in terms of bringing reporting back and the regularity of that. I suppose from yourself, Martin or Patricia, what do you think would be most appropriate? Patricia.
Will I go first?
Yep, you go first.
I was going to say they could probably bring back something very focused around the work they're doing around care homes, probably at the next committee, because they have, each of the localities have been really heavily involved in that, and all the locality managers are part of the whole assurance process. So there is probably something collectively they could bring around that work from a locality basis to the next committee, which would then give you time to think around what other themed areas you would like to look at.
That sounds helpful to me. Patricia, do you want to bring this in?
Yeah, I would expect the committee would probably want at least annually a report from each of the localities giving that overview on care assurance and progress. So, but I think Martin's making a good point about during COVID, we do have the debrief papers later on the agenda, which gives committee an overview of that, but it would be helpful to get that by locality level for the next meeting.
Yeah, that sounds good to me. Anyone else on the committee want to add anything to that? And certainly the point about the annual reports from each locality, I think if we can schedule that in within the plan that's set out on those regular reports. Well, if there's not any more comments or questions, I'll just move on to thank you very much for the report, Martin, and the offers around further reports. And I think if members want to have a think around the themes that are discussed there and where they might fit in with other work that we're doing in terms of the committee. And can maybe feedback if there's things that they feel that in future they think would be helpful and we think would be helpful, and then that's a matter of then looking at how those are scheduled in future committee meetings. So that's an action maybe for us out with this to have a think about that and feedback to feedback to the team about what might be helpful. With that, I shall move on to the programme of meetings 2021 and membership.
Thank you. The report sets out a proposed programme of meetings for the committee for 2021. We're proposing to follow the same pattern of Friday morning meetings, and with meetings being held remotely for the foreseeable future, and can obviously keep that under review. A draft forward planner is also attached to Appendix 1, and taking note of the things we'll have to add to that from the discussion today, but that's also attached for your consideration. It can be changed to reflect emerging issues and priorities and areas of interest to you as a committee. The purpose of the forward planner is to ensure that committee is compliant with our framework and our terms of reference. The report also notes the vacancy for a third sector representative. There has been a subsequent appointment, and I'm linking in with the Chief Executive Officer of the CBS just to discuss IJB representation in general, so we can provide an update both to the board and then to committee. So in conclusion, the committee is asked to approve the recommendations at 2.1 to 2.3 of the report. I'm happy to take any questions.
Thank you very much, Suzanne. I think I mentioned at the IJB, I know it's a mammoth task to try and get everything fitted in and not conflicting with either NHS or council. So I know it's a real challenge. So thank you very much. Can I ask just a quick question, because I think in terms of that the new chief executive of CVS, and certainly I found it, and I think it's important that we have a third sector representative, and I think maybe if you just confirm that the process is that the IJB appoints, and then they would come on to that committee after that appointment. Is that correct?
Yeah, yes, that's true. So we'll take a paper to the IJB committee about membership for both the board, and then note the vacancy for Clinical Care Governance Committee as well on that.
Right, thank you very much. Is there anything anyone would like to add to that? No. Well, in that case, what I'm going to suggest, we have three private items which we are an exclusion of the public. So what I'm going to suggest is we have that they're big items, that we maybe have a 10-minute break and reconvene after that. Give you all a chance to get a coffee. Brian?
Hi, sorry, just to be really bureaucratic, formally you have to agree to exclude the public so that these items become private. So
Okay.
I've taken that you've done that, but I just wanted to get a nod of heads.
Right. Can we formally agree in relation to the exclusion of the public? Everyone either nod their heads or raise their hands. Right.
Right.
I think there's some movement there. Right. Thank you very much. So if we it's let's see, what's my watch? It's 10:37. So if we reconvene in 10 minutes, so that's 10:47 precisely, and that'll give everyone a chance to get a quick coffee.